So the reason we decided to do this event is because a couple of us did our psychiatry placement this year, and we found it quite thought-provoking that the psychiatrists had the power to detain some of the patients against their will, sometimes for years on end. And we thought that there must be some ethical dilemmas to tease out here, which was sort of the inspiration of the event. And one of the cases which will be introduced will focus around a case that we studied during our psychiatry placement. So the way the event's going to work is Medani, Shizang, and George are going to go through a case, and then after each case there will be an opportunity to discuss it amongst ourselves, and then after that we'll hand over to the next presenter. We're going to record the presentations themselves, but not the discussion. So none of you who decide to speak will be recorded. So, like I said, my name's Hector, and I'd now like to hand over to the rest of the committee to introduce themselves.
Hello everyone, my name's Medani.
I'm Shiz. I'm George.
I'm Pavesh.
And apologies from Lauren, our 6th committee member who couldn't make it today. And on that note, Medani, would you like to begin?
Yep. Okay, let me just share my screen here. So I'd just like to thank everyone again for coming. Hope you guys find it interesting and enjoy yourselves. Okay, so I'm going to start off by talking about the patient-doctor relationship and some different models that have been proposed for that. And then, as Hector said, I'll move on to the first case discussion of the night. So let's begin. During the last few decades, there's been a struggle over the patient's role in medical decision-making that it's often characterized as a conflict between autonomy and health, between the values of the physician and the values of the patient. In an attempt to counter physician dominance, many have sought the ideal of greater patient control in medical decision-making. But not everyone agrees with this because I think it maybe fails to acknowledge the power imbalance which occurs here when one party is sick and searching for security, and when judgment entail the interpretation of technical information. Nevertheless, most of us are trying to delineate a more mutual relationship. The struggle shapes the expectations of physicians and patients, as well as the ethical and legal standards for the physician's duties, informed consent, and medical malpractice. And the struggle forces us to ask the question, what is the ideal patient-doctor relationship? So there are 4 models proposed by Emmanuel and Emmanuel of the patient-doctor relationship, which are the paternalistic, which I'm sure most people have heard of, the informative, the interpretive, and the deliberative models. So I'll go through those and sort of give a bit of detail on what they each involve. So in the paternalistic model, patients receive the investigations that best promote their health and well-being as decided by the doctor. The physician uses their skill and expertise to determine the patient's medical condition, stage of disease, and identify the tests and treatments that are most likely to ameliorate the patient's health and reduce their symptoms. The doctor's then selective with the information they share with the patient, the primary goal being to encourage the patient to consent to the intervention of the doctor's choosing. At the extreme, the doctor will authoritatively inform the patient of when the treatment will begin. Alongside the paternalistic model, there are some assumptions. So it's assumed that there are objective criteria for determining what's best, and that allows the doctor to make judgments and make calls on what's in the best interest of the patient with limited input from the patient themselves. And it's ultimately assumed that the patient will be thankful for the decisions made by the doctor, whether or not they necessarily thought that that was the best option at the time of treatment. So in the tension that I mentioned that exists between patient autonomy and well-being, between choice and health, it's the latter that takes priority. So in the paternalistic model, the doctor assumes the role of a patient's guardian, articulating and implementing what's best for that patient. And of course, with that responsibility, the doctor has certain obligations, such as including taking the patient's best interests above their own, maintaining expertise in their area, in their field, and seeking the help of others when they actually don't have enough knowledge on the topic themselves. And here in this model, the conception of patient autonomy is patient assent, either at the time or later, to the doctor's determinations of what is best. So I'll move on to the informative model next. It's also sometimes called the scientific engineering or consumer model. And the main objective is for the doctor to provide the patient with all the relevant medical information, for the patient to choose the medical interventions they want, and for the doctor to execute the selected interventions. The doctor thoroughly informs the patient of their disease state and the nature of the possibility of risks and benefits associated with the treatment and any uncertainties of knowledge. At the extreme, patients can learn the medical condition, medical information on their condition, so that they know the relevant facts, and allows them to determine which treatment best suits them. One assumption which is made is that there's a clear distinction between facts and values. The patient's values are well known to them. What they need is facts, and it's the doctor's obligation to provide that information, allowing them to decide which treatment best suits them. The physician, importantly, doesn't question or judge the patient's values, nor do they attempt to enforce their own. So here we could consider the doctor as a purveyor of technical expertise, aiding the patient to exercise control. And in this model, the conception of patient autonomy is patient control over medical decision making. Next, we've got the interpretive model. And the aim here is to elucidate the patient's values and what they actually want, and to help them select the appropriate medical interventions that best realize these values. So according to the interpretive model, the patient's values aren't necessarily fixed and known to the patient. They're often undeveloped, and so they may only be partially understood by the patient. So the doctor has to help the patient to decide what's important to them. And to do this through dialogue, the doctor will work with the patient to reconstruct their goals, aspirations, commitments, and character. At the extreme, the physician needs to conceive the patient's life narrative as a whole, and from this, specify the patient's values and their priorities. Again, the physician, doesn't judge the patient's values or dictate to them. They simply translate these goals into the most appropriate treatment options. So you could consider here the doctor to be a counselor. One analogy you could use is that of a cabinet minister who would help the head of state by translating political policy into political ideals that the party aspires to. And in this model, the conception of patient autonomy is self-understanding. The patient comes to know more clearly who they are and how the various medical treatments bear on their identity. And then the final of these four models is the deliberative model, which has a lot of similarities to the interpretive, but there's some key distinctions. Here the aim is to help the patient choose the best health-related values that can be realized in their situation. So the doctor needs to delineate information on the patient's condition and help elucidate the types of values embodied in the options available to them. Unlike the interpretive model, here there is a place for the doctor's judgment as they engage the patient and attempt to convince them that certain health-related values hold the most worth and should be aspired to. At the extreme, the physician and patient engage in deliberation about what kind of health-related values the patient could and ultimately should pursue. And when I speak of values, that's solely in relation to healthcare outcomes. Any elements of morality unrelated to the disease are beyond the scope of this professional relationship. And it's important to emphasize that the doctor aims to achieve no more than persuasion. It mustn't cross the line into the territory of coercion. And you could consider the doctor here to be a friend or a teacher. Not only do they indicate what the patient could do, but knowing the patient and wishing what's best for them, they suggest what the patient should do, what decision regarding medical treatment would be admirable. And the conception of patient autonomy here is moral self-development. The patient is empowered to consider through dialogue alternative health-related values, their worthiness, and their implications for treatment. So there's a lot to consider in terms of protecting patients' rights and ensuring that doctors act in an ethically sound and admirable manner to reflect the gravity and responsibility of the power they hold in patient care. Two dominant features in the practice and in the literature are those of autonomy and consent. They're both relatively new concepts in healthcare, so their merits and how well our healthcare system satisfies these values is constantly under scrutiny. And when you look at the 4 patient-doctor interaction models proposed by Emmanuel, you can't choose one over the other on the basis of consent or autonomy, because you could argue that all of them allow the patient the opportunity to consent and have autonomy in treatment, of course, with the exception of paternalism, where autonomy is kind of in contradiction to that style of relationship. But when speaking about consent, it's always the patient who must give or withhold it. But a paper I read by Habiba makes some interesting points about consent. And she goes on to suggest a new model of the patient-doctor relationship, which aims to ameliorate the shortcomings in our current models. She argues that patient liberty can't be secured unless consent is either withheld or once it's given, the freedom to withdraw it is maintained. And therefore, it's the absence of consent or the ability to withdraw it and not its presence that safeguards liberty. In other words, although the possibility not to give consent safeguards liberty, it only does so until consent is given. Essentially, she argues that, at least in the forms common in current practice, consent is no more than a formality and somewhat of a sham. She supports a relatively new idea of a request-based relationship, which has quite a lot of similarities, in my opinion, with the informative, but there's, again, some slight key difference. So in the request-based relationship, it involves well-informed patients who reach their decisions after consultation with the relevant doctors, and then choose to enlist the help of professionals to achieve their goals. And she suggests that it's not the doctor who should be seeking the consent of the patient, but instead it's the doctor's consent who the patient should seek to achieve. And it's within that context that the doctor can exercise their duties of beneficence and non-maleficence. She argues that this could be a better way to satisfy consent and empower patients in their own healthcare choices. So with request, patients remain in control, and this encourages responsibility for their own health. And the doctor's duty changes from obtaining an informed consent to fulfilling an informed request, which I thought was quite an interesting twist on the concept of consent. So that wraps up my sort of introduction to the event tonight. And I'm going to move on to our first case study now. So the paper I read about this was titled Neither Consenting Nor Protesting, and you'll come to see why that is as I outline what actually happened. So it involves Mr. L, or HL, who is a 48-year-old man at the time of this incident, suffering from autism, profound learning disabilities, and he is aphasic, which for any non-medics in the crowd, you might know anyway. But that essentially means that he can't speak. So he had lived in Bournemouth Psychiatric Hospital from the age of 13 for over 30 years before resettling with his foster carers at the age of 44, and they're called Mr. and Mrs. E. But on the 22nd of July 1997, he was visiting a day centre, and one of the conditions of his discharge from Bournemouth was that he would attend this day centre once a week. On that day, the bus driver took a different route and picked up new passengers, deviating from the routine which is well known to Mr. L, and that caused him to become agitated and panicky. He had a long history of tantrums, as described by Mr. and Mrs. E, but they managed these at home without involving professional help, and largely they thought that his tantrums were becoming more infrequent and that he was developing adaptive behaviors to help him manage. But at the day center, he did have a tantrum where he repeatedly headbutted a wall and punched his own head. So as they should have done, the staff called the ambulance. Mr. L was then sedated and taken to A&E. At A&E then, a consultant psychiatrist did a mental health review, and he deemed it necessary to admit Mr. L to a Bournemouth psychiatric ward in order to protect him from self-injurious behavior. As I've mentioned, Mr. L can't speak and he was sedated, so it's hardly a surprise that he was compliant. And because he didn't protest, the psychiatrist decided not to invoke the Mental Health Act and admit Mr. L as a voluntary informal patient. And that's quite key to this case because informal patients aren't afforded the same legal rights and protections as formal patients. So there's a few significant advantages of being a formal patient under the Mental Health Act. So I'll tell you a few of those. Firstly, a formal patient has access to the Mental Health Review Tribunal, which reviews criteria for discharge, and access to the Mental Health Commission. And the Mental Health Commission itself investigates complaints by and on behalf of formal patients. Also, unlike informal patients, formal patients are entitled to a second opinion for certain treatment for a mental disorder. And as well as that, after discharge, formal patients are entitled to aftercare, which might not necessarily be offered to involuntary patients. So by admitting Mr. L as an informal patient, he was denied those legal protections and he was denied independent supervision and review. I think I speak for everyone when I say that an aphasic, sedated patient who simply complies doesn't necessarily amount to that patient consenting to what unfolded. Mr. and Mrs. E, to compound the issue, weren't made aware of any of this, and they didn't know about what was going on with him until he'd actually been admitted to the psychiatric ward. And the way in which they found out was by receiving a letter from Bournemouth Hospital thanking them for agreeing not to visit Mr. L. That was the first they'd heard of it, so of course they hadn't agreed to anything. And the psychiatrist's reasoning for this was that up until that point, he had been compliant, and they were afraid that if Mr. and Mrs. E came to visit him, he would become unsettled and want to leave with them. The psychiatrist also maintained that had he protested and refused entry to the psychiatric hospital, that he then would have invoked the Mental Health Act. And if he tried to leave at a later date from the psychiatric ward, that he wouldn't have been allowed to. So I want to pause there for a second and ask you guys if you've got any thoughts about what should have been done up to this point, what was done well, and what could have been done better in order to protect a vulnerable patient like Mr. L. And his admission amounted to a detention or false imprisonment. This was then appealed again and taken to the House of Lords, where their ruling maintained that such treatment did not amount to detention or false imprisonment. They argued that in order to serve Mr. L's best interests, such as preventing him from harming himself, the common law doctrine of necessity meant that the psychiatrist's actions were acceptable. But it was later found that the Mental Health Commission had informed the House of Lords that had they ruled his admission to be unlawful, the knock-on effect this would immediately lead to 22,000 informally detained patients having to become formal patients, and across a year that would lead to an extra 50,000 invocations of the Mental Health Act to detain incompetent but compliant patients. The financial backlash that would have on an already underfunded segment of the NHS was deemed to be just too large, and that seemed to be the main motivation in their ruling. But on the face of it, they attempted to say that they were ruling as they were because of his best interests. But I think you could argue that Mr. L's liberty is also something that should come into his best interests and not purely his physical health, in terms of the fact that they were trying to prevent him from physically harming himself. Mr. and Mrs. E said that when he was eventually released after 5 months, that he was in a terrible condition. He had a lot of bruises all over his body. He'd lost a lot of weight. And for the first month that he was back living with them, he did nothing but eat and sleep and wasn't really himself. And they felt that the frequency of his tantrums had increased again, and that they had got a bit worse. So it could be argued, I guess, that being admitted back to Bournemouth wasn't the best thing for his best interests, both in terms of his liberty, of course, and also in terms of physical harm to himself. So after the ruling against their favour by the House of Lords, they decided that it just wasn't acceptable for vulnerable patients to be subjected to that kind of abuse and that kind of neglect. So they took it to the European Court of Human Rights, and they actually ruled that he had been deprived of his liberty unlawfully based on Article 5 of the European Convention on Human Rights. And that's had knock-on effects. You'll be glad to know. The UK government launched a widespread sort of investigation about what the potential consequences of this ruling was. And after looking at the system, they found that compliant but incapacitated patients in care homes and in hospitals might be deprived of their liberty with things as they were. And that resulted then in the amendment of the Mental Capacity Act in 2005, which they added the deprivation of liberty safeguards, and these came into effect in 2009. But apparently their uptake hasn't been as widespread as would be hoped for, and there still are a lot of patients in this position who lack capacity, but are compliant, and their liberty is potentially something which isn't necessarily taken into concern when making decisions. So that's what I've got to say about that case. And that's the end of my presentation. So thank you very much for listening. Hope you enjoyed it.
Okay, lovely. So I'm going to be taking a slightly different tack to what Madani said, building on some of the principles he's talked about. But in terms of patient power and autonomy, I'm going to be talking on a bit of a bigger scale about the topic of coercive paternalism, which I'll explain in a bit more detail as we go forward. But I've started off here with an introduction to autonomy, and I think Madani really discussed autonomy in very good and clear detail. Just like I've highlighted here, as the patient-doctor relationship evolves and as different models are proposed for this relationship, the autonomy of the patient has moved from something that, maybe 50 years ago was quite neglected under a paternalistic relationship, but nowadays with more of a push towards shared decision making, it's more valued than ever before. And I've talked a bit about here what autonomy really means in a medical context, and I think one of the most important things is to say that it doesn't give patients a right to demand treatments. Autonomy is the capacity to make an informed, uncoerced decision about your own body. And in medicine, that manifests as being able to refuse treatment, but it doesn't give any allowance for you to successfully or for a doctor to give in to a patient's treatment demands. And in order to facilitate this increased autonomy, doctors now often talk patients through a variety of options. I'm sure all the medical students here have heard about conservative treatments, medical treatments, surgical treatments, kind of escalating up that ladder. And doctors will now pitch a range of treatments to patients and give them their opinions. So that patients can exercise their autonomy and select from those. Now, paternalism, by definition, infringes on an individual's autonomy, and a lot of arguments against paternalism center around restriction of people's liberty and restriction of people's autonomy. And that's a question and a talking point I'll throw out towards the end. So autonomy is the chance for patients to make informed and uncoerced decisions. And all human beings are capable of making rational decisions. I've defined rational decisions here as those which allow an individual to reach their desired ends at the least cost. But I know, and I'm sure all of you in the audience know as well, but although we're all capable, we don't always make rational decisions. There are many reasons why humans would not make a rational decision. Lack of foresight, misinformation. You can't make an informed decision if you don't know all the facts. And cognitive bias. And I've given some examples of cognitive bias here. In my opinion, these are some of the ones which are perhaps more relevant for some of the arguments about coercive paternalism we're going to be talking about. So for example, optimism bias. This is, if we use smokers as an example, optimism bias can be described as a smoker saying, oh, well, I won't get lung cancer, other people will, but I won't. Present bias, so, I might get cancer 50 years down the line, but the cigarette's going to be really good right now. Trading off your future losses for a smaller present gain, because your future loss is less tangible than your present gain. And confirmation bias, which I think applies to this example, but also in many wider examples as well. So coercive paternalism. Sarah Connolly, in her book Against Autonomy, defines it as intervention of the state in certain situations to prevent individuals from making decisions that they would have made without the intervention. And the entire purpose of coercive paternalism, in theory, is to push patients, well, individuals, into making rational decisions, into making decisions that will benefit them the most, give them the most net benefit. In practice, how coercive paternalism would manifest is through increased state regulation, and this could be through bans, like I've listed here, bans of certain products, bans of certain, ban of the sales of different things, or restrictions and regulations on different industries to determine how they can operate. So these kinds of bans and decreasing the availability of and decreasing the choice of consumers in this way is referred to as hard paternalism. And hard paternalism is the use of coercion, as I've said here, to alter the outcome of a fully voluntary decision. And you can see this is in contrast to soft paternalism. And I think the key point to pick up between here is the difference between a non-voluntary decision and a fully voluntary decision. So as I've said here, a non-voluntary decision is someone who smokes and continues to smoke, maybe because they don't know about the harms of smoking. You can't make a fully informed decision about your decision to smoke if you don't actually have all the required facts to weigh up the pros and cons. Whereas hard paternalism would be an example of a smoker who, a fully voluntary decision rather, is an example of a smoker who continues to smoke despite knowing the facts. They've made up in their own mind that smoking is either best for them, or due to other cognitive biases, they haven't made a rational decision. And one of the rationales for pursuing hard paternalism as opposed to soft paternalism is that soft paternalism doesn't work as well in this given example. Obviously, hard paternalism is more of an intrusion on individuals' autonomy and individuals' liberty. But as we can see here, even if you increase education, correct these information inequalities and reduce misinformation amongst the general population, 20% of Americans continue to smoke even after they've been told about all the negativities of smoking. And there's lots of different reasons, which will open this up for discussion at the end. And one of them is, you could call it a cognitive bias perhaps, but people don't value their health sufficiently until they lose it. This kind of comes back to, small present gains in favor of larger future losses. Things in the future, especially something which can be a bit abstract. A concept such as your health is not very tangible, not really that. It's not really that tangible. It's hard to really think about it and value it or determine your own subjective value of your own good health. And that's a reason why some people would say we should push for hard paternalistic measures, because sometimes people don't know what they really want. And commonly suggest some of these as criteria for what a good hard paternalistic or coercive paternalistic intervention would need to fulfill. 4 points. I think the third point often comes up in economic arguments against many coercive paternalistic interventions. For example, if you were to ban cigarettes, the cigarette industry, tobacco industry has a massive lobby, is worth lots and lots of money, and the benefits of interference, although great, reducing lung cancer risk, reducing lots of pulmonary pathology, would be weighed across, the costs of fighting legal battles in order to fulfill and uphold these regulations. The first point as well is often up for debate. So it has to conflict, the activity that's going to be modified by the intervention has to conflict with an individual's long-term ends. Many people don't know what their long-term ends really are. And in terms of a pragmatic perspective of implementing an intervention, individuals have very heterogeneity. There's massive heterogeneity between people's values and people's long-term ends. What one person values very highly, such as their good health, may not be valued as highly by another individual. So it's very hard to account for this kind of difference in thought within the population when you're implementing these kinds of strategies. So this is one possible case where you could make a good argument for implementing a coercive paternalistic intervention, which is to ban trans fats, because trans fats have really no benefit to consumers, but many documented negative effects by increasing rates of cardiovascular disease. And the consumption of trans fats does generally stem from irrational decision making. You could argue that any decision to consume these products is irrational because there are no benefits to having something that has trans fats as opposed to one that doesn't. So by banning the availability of this, the state has intervened and corrected this irrational decision making with a very paternalistic intervention by removing it as a possible option. As I talked about earlier, this is one of the biggest problems with coercive paternalism, is that different individuals have different values and they value different characteristics and traits with different weightings accordingly. And you could say that coercive paternalism really is just an attempt at perfectionism. it's making or attempting to make the general population adhere to one specific end, which is not necessarily an end which individuals actually want to work towards. The second point I've talked about here is also interesting. If I, want to smoke a cigarette after I've had a few beers, that might feel nice, but it also directly opposes any desire I have to be healthy or to be healthy in the long term. And it really comes down to the crux of the fact that humans have multiple different desires, and many of them can be conflicting, and many of them can be mutually exclusive. And perhaps coercive paternalism would require people to prioritize their desires in a manner which isn't really feasible. So I've just offered a little short introduction about coercive paternalism and a short case, the trans fats case. Smoking is another interesting case, but I didn't go into it in case people wanted to discuss it. But I've just got some questions here for people to think about, if they had any other thoughts about what I've talked about. But yeah, a lot of arguments against coercive paternalism are about intrusions on liberty, intrusions on autonomy. But what really is the value of autonomy? Does autonomy have any intrinsic value? This is a question I thought about 10 minutes before I gave this presentation, so I don't have the answer either. So if anyone does, that'd be much appreciated. And in a more modern perspective as well, obviously there's some degree of backlash over the Conservatives' decision to publish calorie information on all menus for a variety of reasons. It's interesting how you could link those perspectives back to general ideas of coercive paternalism. But no, thanks everyone for listening. And if anyone has any questions or thoughts, I'm more than happy to discuss them.
And the case study that we're going to be looking at is about gift giving in the medical student-patient relationship, and the challenges that this might pose to the power dynamics that we see between patient and practitioner, especially because this sort of dynamic is something that people don't really consider as much. It's always the the doctor-patient relationship and what sort of intricacies we might see when we're considering medical students. So the case itself was written by a medical student, and the summary is there was a medical student who was had a specific encounter with a patient, Mrs. H, on the ward, and as you do, the medical student wanted to take a history and do an examination of the patient just for his own learning. So he consented her for this. He wanted to write the case up, and he took sort of thorough medical history. To complement this, he chose to come back the following day and do a thorough physical examination of her so he can include any sort of pertinent signs in his case write-up. The patient consented. It's obviously the right thing to do to ask for consent in this context. And she replied, yes, of course, but then added, you'll have to bring me some cheese scones and coffee if you want to do this. And the medical student, to be honest, as I think a lot of us would in this context, was a bit embarrassed and quite sheepishly just said yes. And he sort of went away from this and had a couple of issues running through his head. I think maybe the first one was actually, am I going to get GMC for this? The answer probably is obviously no. But he did sort of come away thinking about the ethical underpinnings of what he was being asked to do. And when it came to his answer and why he said yes, there were sort of two things that leapt to mind to him as to why he said yes. The first one was his cultural background and that he had been raised to respect his elders, and the patient, as an older patient than him, sort of fulfilled this role. And also that the second one is that he felt indebted, and that the patient had given up her time and actually a certain bit of her sort of physical body for the patient, for the medical student to examine her, and actually he felt the right to pay her back for this in some sort of context. And the medical student left this scenario with a couple of questions. Firstly, why, of all of the members of the healthcare team on the ward, why was he the one that was asked to buy her scones? And secondly, was it ethical for him to answer in the way he did? So with respect to this specific decision, there's a couple of questions about how we make decisions in line with morals and promises, and actually, understandably, because it's not a major issue, but there's relatively little ethical guidance and published literature on gift giving within the student-patient relationship. As I said, there's a lot talked about in the context of the doctor and the patient, but this is a relatively little explored area. And that also goes true for the dynamics of the medical student-patient relationship. And actually, the traditional dynamics that we see with respect to gift giving, which I'm sure a lot of us are familiar with, especially if you are sort of medical students or in the career of healthcare. And actually, the scenario that we're presented here is actually quite different to the scenario we might expect in the context of doctors and patients. So how does it differ from standard ideas of gift giving in the medical profession? It has been reported that patients tend to say things to medical students which they wouldn't usually disclose to their physicians, and I'm sure a lot of us have experienced this, and there are several explanations for this phenomenon. The first one obviously being an age difference. A lot of us are young, ranging from 18 to early 20s, the majority of us, and that's often quite young, than patients who are sort of several times our age, really, that we see in hospital. And also, whether we mean to or not, we probably do give off a certain amount of naivety, and people may find that endearing. There's also a lot of extra time that we can offer patients because we don't have the same time pressures, understandably, as employed staff in the hospital. And then actually the patient in this context is really doing the student a service with respect to his learning. And with respect to gift giving in the traditional doctor-patient relationship, there's quite different dynamics that are seen here. And there's obviously a huge amount of gratitude that patients might have for the doctor and the interventions they give. There are certain other dynamics that might actually play into this and make this a bit more complex. So obviously the idea of the gift being a tip and being a sort of route of access for patients to get out-of-hours service or enhanced care and things like that. The gift may also be recognised as an ability to ward off the bad. This is might be a sort of subconscious cognitive sort of bias there. The gift may be used to reciprocate time or healing, so as a sort of payment in that respect. And it also may be used to address the imbalance, because there is actually a huge amount of imbalance between the doctor and the patient relationship, because obviously the doctor is the gatekeeper to healthcare and things like that, and there is the potential for a huge power imbalance in that context. And actually, the idea of gift giving may help address this imbalance. So why is gift giving not the other way around? So obviously, in the context of doctors, receiving gifts from patients is actually a quite common phenomenon. But why isn't it the other way around? And why do we see this other reverse relationship among medical students? And this is quite an odd scenario. And medical students do fulfill quite a different role in this context. So doctors obviously have a salary, which medical students do not. Medical students also don't really fit into the team in the same way as doctors do. We also don't tend to have any responsibility for the services we're providing. And in that respect, these contexts of gratitude or things like that, or addressing the imbalance, don't really apply in the same way. And actually, predominantly, our role in hospitals is to learn from patients, actually. And in that respect, patients are often providing us with a service. And they're sharing not only their time, but also sensitive and intimate information, and also the sort of physicality of their bodies and things like that for examinations. So often it's quite understandable, actually, that students might feel indebted to these patients for these opportunities. But there are some sort of other interesting points about this case as well, and that's firstly that gifts are not usually requested, and nor are promises given for gifts. Gifts are something that are usually given unconditionally. There are also implications for the use of sort of monetary gifts in the context of the necessity to pay for the privilege of learning and the privilege of using patients for their histories and their stories and things like that, and the implications that might have. And actually, Lauren's put here the tip of the iceberg, and actually, whilst I don't think many of us have bought scones for our patients, I think a lot of us have had to have negotiations and have felt the peculiarities of the relationship that we have with patients versus doctors. So in terms of finding a possible solution to this, there may be a bit of a middle ground. So examples might include channeling the monetary gift to a charity under the doctor's and the patient's names, so as to not have the exchange of money, which is quite problematic, and also substituting the gift with another that could be given to the whole medical teams for the benefit of everyone, so as to not endorse this very sort of specific relationship that you have with a single patient. But the gift was requested from the student. And what did the student do? So I think there are a couple of questions that are going to come next, which might help us work out what the right thing to do in this context is. But I will sort of disclose afterwards what happened. So some of the questions that Lauren's put here is whether gift giving in any professional setting is an ethical thing to do. Obviously, medical student-patient relationships are quite, more unusual, but I think, we're all very familiar with the idea of patients giving doctors gifts. Does it pose a threat to the professional nature of this relationship? Is it just the medical profession that would be flagged in this, and why, and what particular problems are there with the use of gift exchange in medicine? And should the case of a doctor receiving a medical student versus just the doctor receiving a gift versus the medical student differ? And what implications are there because of this? So I'll open that up to everyone. Does anyone have any stories of gift giving? He did ultimately choose the middle ground, which was he did buy the scones, but he bought them from a wholesale store, so they were as cheap as possible. And this sort of reduced this idea that there is any sort of monetary exchange for care in this context. And he also decided to share it with all other people on the ward, so not just the patient, because there is this also the issues which we haven't really touched on today about sort of favoritism and prioritizing sort of reinforcing relationships you have with certain patients over others through the context of gift giving. And actually, ultimately, the nurse in charge told her that she was very happy with how this made the patient feel, and ultimately she gave the student a thank you card saying thank you for how kind he was, not just to the patient but for everyone on the ward. So there was obviously a good outcome in this context. But yeah, so a narrow GMCing, narrowly missed GMCing there, but made it through.